Good morning and welcome. Today we're going to start by grounding ourselves with a brief overview of the U.S. healthcare system, its structure, key players, and important trends that are shaping its future. Leading us in this discussion is Dean Staats, the Ellison Distinguished Professor for Operations and Senior Associate Dean for Strategy and Academics here at UNC Kenan-Flagler, and also a leader for the UNC Center for the Business of Health. Please join me in welcoming Dean Staats.
All right, thanks, Sean. Thanks for being here, kicking off the day and spending this incredible day diving into the U.S. healthcare system. It really is a treat to be this first session to try to help level set us. Across this room, we really run the gamut. We've got folks who I'm sure are here with, healthcare seems pretty interesting. I might want to do something there, and kind of start from that base. Awesome, glad to have you. We have folks in here who are really deep in certain aspects of it, and are thinking about how do you push that further? How do you kind of broaden that out? And so that's always fun to get to do the overview in that context, because I appreciate, okay, what's the level, where do we stretch it out? Want to make this interactive. To the extent you have questions, great, throw the hand up. To the extent, you hear something, you're like, I don't know that that's exactly how I see it, because I spent the last, X years working in biopharma or wherever it might be. Wonderful, throw that out too, because I think what, I hope we come out of this with is certainly some terminology, some understanding of the pieces, but also recognition that the U.S. healthcare system is kind of a system of contradictions, that there's a lot to like, and there are a lot of things that we can keep working on together. And so let's dive into that. If we just kind of think of many players, there's all sorts of maps that you can try to look at as we sort of try to capture what is the U.S. healthcare system. And I think there are two things I would want to highlight out of this. First and foremost is there's a reason that people are at the center. And that's something that, wherever you sit in the healthcare system, we never want to forget, right? Why are we doing this? It's, right, to make people healthier. Why are we doing this? Because eventually the mirror reflects back on us. That, one of the really compelling parts of working around health is at some point it's touching you personally, right? That, I won't, but if we were to all think about, whether it's you individually, whether it's someone in family, whether it's friends, what are the ways that healthcare has created opportunities, done amazing things, and then also you can probably come up with some examples of, oh yeah, this was a bottleneck, this was a roadblock, and that kind of that centrality of the patient, of really the people that we think about it. We will all be patients at some point. Then, we start to radiate out, right? And there's all sorts of ways we can try to organize this. Here I went with the complex one. I'm a big fan of thinking about it in terms of P's, that kind of people or patients in the middle, that we can think about providers and all that's contained there, whether that's kind of doctors and PAs and nurses and pharmacists and hospital administrators and all of the things that wrap around kind of the delivery of care. We can think about the payers, and I'm going to unpack that a little bit more. Where does the money come from? I would strongly encourage wherever you end up, one of the things to think about is what do the funds flow look like? Because if you can track the money, then you can understand better what are the incentives, how are things working. Some places you may be aiming to maximize kind of the return, that's great. And plenty of others, it's, I just got to get enough, right? No margin, no mission. And so how do I solve for that? But either way, understanding the money and the payers that go with that. The policy side of things, I'm going to touch a little bit on policy. That's certainly not kind of my depth of expertise here, but we need to understand it. And it's an important piece that you can't look at healthcare without thinking about policy. If kind of you're the most dyed-in-the-wool business person, you're like, no, I don't deal with the government. Yes, you will in healthcare, in U.S. healthcare. There's no avoiding it. And so you better lean into it and think about, okay, what does that value look like, right? I would argue the other side too, if you're really deep into just kind of the policy government side, I don't deal with business. I would say, yes, you will, right? You can be more insulated on these things but the power is really bringing it together. And that's certainly kind of the plug. Later on, Suzanne will talk about the center. But the goal of the center is how do we bring folks from across Carolina, right? We're sitting right now in the McCall building, the business school, that's fine. But this is not meant to be, hey, let's tell you about kind of business. It's, hey, how do we think about across this great university, all of the things that are happening, and how do we work as a hub to tackle this? Last P, briefly hitting on, and you can see the various names, is thinking about, I'll call it the products, right? Whether that's pharma, whether that's digital tech, whether that's medical devices, diagnostics, right? Lots and lots of things that kind of plug in and help us kind of move forward. So if this is kind of a very high level overview, what do I want to talk about kind of to level set? 4 things that we'll hit in the next hour. Kind of who's paying, who's getting care, what kind of care are they getting, and then sort of, and how's it going, right, as we think about these various pieces. And, again, we could spend I'll say we could spend an entire day on each one of these, and that would be kind of woefully underestimating the amount of time, right? We could spend an entire course. You could get most of a degree. So, goal is, hey, can we paint with a broad brush? Can we get excited as we understand some different pieces, and then figure out where to go? So let's start with kind of who's paying. One of the things I'll highlight as we look at data in healthcare, that it is often kind of lagging some amount, right? That as with kind of lots of big bureaucracies, it gets captured, it then rolls its way up, it then gets calculated, it then slowly makes its way back down. And so within an organization, we may be working real time. On the meta side, we're often kind of playing a little bit behind the game. But if we think about expenditures in the US, right around $5 trillion, important difference, at the moment. I think 4.9 trillion, kind of the last number we have to work from. And then we can think about kind of the expenditures. And I'll unpack this a little bit, but at least out of this data, 30% of it coming from private health insurers. So this might be United Health Group, and Aetna, Cigna, the Blue Cross Blue Shield in North Carolina, as you think about perhaps where your health coverage comes from. Medicare and Medicaid are 2 biggest government programs that I'll talk about in a moment. Primarily Medicare for those over 65, primarily Medicaid for those lower socioeconomic status and kind of in need with, again, some exceptions. Out of pocket, right? Think about when have you individually paid for healthcare and what that looks like. And then this last bucket is sort of a catch-all. It runs from Children's Health Insurance Plan, Department of Defense, and Veterans Affairs on kind of military side, public health, things occurring at some of the state side. So as you look at this, kind of what do I want you to take away? Being paid by a bunch of different parties, that's going to make coordination challenging. And also, we talk a lot about in the U.S., right? One of the discussions, certainly last presidential election before, well, how do we think about single-payer health? How do we think about the role of the government? Should we look like other countries around the world and have kind of one approach? Do we have a market-based approach? These are all really important policy questions, but recognize when you start to do the math here, that what you will see is a majority of care is paid for through governmental sources in the United States. Now, a majority of individuals in the U.S. are covered by private plans, and kind of why is it? We'll get into it, but people are really expensive, so we're covering fewer people. Not shockingly, as we get older, we have more needs and things like that. But in the U.S., a majority of expenditure is from the government, right? Back to why do you have to make sure you're paying really careful attention to the role of government, because it shapes everything that we're doing. Now, I'm going to kind of woefully undercover what's going on in Medicare and Medicaid, because we at least need to know the terms enough. And I appreciate kind of, as we all step into this, some really deep in this, some, okay, I think I heard that term once. And, at first when you stare at Medicare and Medicaid, it's like, those are the same thing. No, right? Really important differences as we look at them. What do I think you need to know? Okay, so Medicare, primarily elderly, right? Some disability illness shows up there. There's actually 4 parts of Medicare that I'm only going to briefly touch on. Kind of A and B is where it started. A and B is kind of covering, the basics of somebody 70 or older has to go to the hospital, they need care, and how do you pay for it? And it got split for lots of historical reasons that I think are fascinating, but are probably not germane for today. Then along came Part C. This is Medicare Advantage, if you know the Medicare market. And basically what this was an attempt to do managed care by the government. How do we wrap A and B together? And we're going to use the private market, and so you're going to be able to go get a plan from whomever it might be, United Health Group, and they are going to basically provide your care, right? The idea here was we're going to create market forces to this term, bend the cost curve. You hear it a lot in the healthcare space. We're trying to bend the cost curve. Now, when I first heard it, what I thought that meant was, health expenditures are going up. We're trying to bend the curve. We want them to go down, right? Which maybe we do, maybe we don't. But that's not actually what we mean in healthcare. What we mean in healthcare by bending the curve is how do we slow it down so it's not growing faster than inflation? Because if we look over the last many decades, with some rare exceptions, healthcare has kind of grown faster than inflation has grown in the US. Right? It's grown faster as we think about then kind of GDP. And so that creates questions of, is that then going to continue to eat up more and more of our total expenditures? And how do we feel about that as a society? So this is meant to be kind of an improved cost, improved quality. The answer is sort of, maybe. And that's often when we look at things in healthcare. There are places it's been really good. There are places that we have questions. Part D was second George Bush. Prescription drugs primarily weren't covered by Medicare, and this brought them in. And then, of course, that meant the federal government had an even more significant role in things like biopharma pricing that you can think about what that means. How should the market set that versus the government? Second piece is Medicaid. This is one that's gotten a lot of attention. I have a couple slides to talk about, but primarily lower income, pregnant women, children. This is sort of the state stepping in of, hey, we want to provide care in certain places for folks, and we've seen a lot of changes in this space. Let me pause here. Again, I appreciate some of you are like, yeah, know it, and some of you have never seen this before.
Would you mind just recapping managed care and then managed Medicare?
Yeah, so it's a great question. So think about I'll simplify it this way. On those parts A and B, if you're in traditional Medicare, then for the most part, you go to the hospital, you get the care you need, and the government's paying your bill, and you're kind of just separate from that. The idea of here is much more kind of standard private insurance. The same thing that you might get from the employer you're going to go work for at Amazon, and they're buying your care. That Amazon pays, and then the insurance package, kind of here's what's included, here's kind of where you have to cover things, here's not, but kind of the federal government pays over a certain amount of money, and it's like, hey, you're now in charge of the care for Brad, with some exceptions of what can overshoot it. And the idea here is, okay, well now you have $10,000, and if you use that money well, then you get to keep some extra profits for yourself. And if the cost goes too high, we're pushing the risk onto the insurance plan. Okay, and so managed Medicare is just a type of that sort of service. There's a lot more kind of as we get into the details of, okay, here's the network that you're working in, right? Who are the different doctors you can go to? The services that are provided are structured by the government. And so that part kind of falls within that. All right. So this is just looking to this Medicare Advantage point, how has it grown over time, right? And this is part of why we're having so many more discussions about Medicare Advantage kind of on the policy side. Certainly, if we look at health insurers right now, is that we did over the past couple of years crack into a majority of Medicare recipients are getting it through Medicare Advantage. Which then means, okay, how is that good? Is it, and we can sort of think about there's constant balances, trade-offs that we're looking at. The good part of this is you get, as the federal government, some cost control. You know roughly what money is going out versus in traditional Medicare, people can go consume different services because they need them, right? And you're just paying for the whole bill effectively. Here you get some of that cost containment, but the danger, imagine all of the healthy people who are getting Medicare go into Medicare Advantage, right? The ones that don't actually need much. Well, then maybe you're actually paying out a lot of money as the federal government and not getting much in return, right? And so that's an enormous discussion taking place right now of, okay, what do we think of this? What are improvements we need to make? How do we understand it? And kind of really significant debate here, but extraordinarily important. We can also think about this discussion in the US of how do we fund Medicare and Medicaid? And so let's talk about each. Medicare is reasonably straightforward. When you have a job in the US, you're going to put money towards Medicare. So it's kind of money that's going to, in theory, pay for you later, but in practice, it's going to be used today to pay for the folks who are going through. There are premiums. It depends on different circumstances, but you may be putting money in, right, to get your Medicare. And then the federal government, a big chunk of the federal budget, right, goes to pay for Medicare. Okay, so different chunks there. On the Medicaid front, this is important. It is a mix of federal and state funding, right? So the politics become kind of really important, that the federal government puts money in, and then states, in most circumstances, put money in. The federal government puts money in, and again, you don't need to actually remember, oh, it's the federal medical assistant percentage. That's not the important part of the slide. You can remember that if you want to. It's more, oh, the federal government puts in different money across the nation based primarily socioeconomic factors as they do this, but it runs from kind of, think of that 65% down to the 55%. Why is this important? Because recognize then the state has to put in the rest, okay? So the state is putting in money for this balance, and then that means there's a real decision that you have to make. So the next slide, I think, is the Medicaid expansion. The Affordable Care Act, known as Obamacare, I'll talk about briefly later. Basically, one of its goals was to expand Medicaid, right? To try to provide Medicaid for more people. Because you can think about it, an important question is sort of what is the income threshold at which you're going to allow people to come into Medicaid? And as you kind of raise that number up, more people get Medicaid, but obviously they have a little bit more wealth, and so how do you think about, is it enough? What should the government do? And that has primarily been a state decision. Do you expand or not? And what we see is gradually more and more states have expanded. In the past couple of years, North Carolina joined that group under Roy Cooper and General Assembly, kind of came to a compromise to do that. And the federal government provides some funding to encourage, at least at first, some additional funding. But eventually the states have to pay for it. And why do I think it's relevant just as, for a kickoff, like, wow, Brad, that feels kind of in the weeds. It's back to a bunch of players, right? Can't avoid the government. Can't avoid, and it's not just one government, right? That we have federal, Center for Medicare and Medicaid Services, but lots of state governments making choices too. And, think about if you were a hospital in North Carolina and Medicaid has not been expanded, right? What happens? Somebody comes, they get indigent care from you. If they need emergency care, hospitals are not allowed to turn people away. You have to effectively stabilize them. And then we have some hospitals that go even further. Well, what if no money is coming in? Okay, then we have to figure out where do we get the money to balance this out so that we can continue to operate. When Medicaid expands, well, maybe that's good because now you can afford to pay for those different things, right? Challenge is, well, what if the Medicaid rates aren't high enough and now you're having to offer services you can't afford, right? I mean, all of these are things that you're going to dig deeper into. Certainly to the extent we take classes and such together, we'll dig in deeper together. But these tensions, right, are very real as we look at U.S. healthcare. Okay. I'm going to kind of, that's a stop of the sort of who pays. And I want to get into kind of who gets care, what does that look like, and dividing that up some. I am going to press on just because I want to make sure we get through the different pieces, and then if we have some more time at the end, we can look at it. Okay, so one of the things that's certainly relevant if you step into the U.S. from another country, this is a slide that tends to get one's attention. Because when you say, who gets care, in many countries the answer is, well, everyone. And the U.S. Does not have universal care. This captures over time kind of what has it looked like. And so, effectively, what you see is that big drop shows up as the Affordable Care Act was getting implemented. And we'll get into the details, but the Affordable Care Act primarily was a story of increasing access to healthcare, paying for more healthcare, and came falling down dramatically, kind of went up around the COVID time, a little bit messy with the data also, and then 9.6%, I think, is the uninsured rate from the most recent data. So we've dropped below 10% with this latest push, primarily around Medicaid expansion, but a little bit else. Recognize, my goal is to kind of lay out facts. This is a great question to wrestle with, right? What does one, not asking this to discuss now, we don't have time, we could spend the rest of the day, right? But what does one think this number should look like? That's a societal question, that's a political question, that's something that is absolutely worth debating, right? Do we think that number should be zero? Do we not? How do we pay for it? What are the trade-offs that we make in order to do this? But as we look at it, recognize 10% of folks don't have insurance. That uninsured rate is not kind of evenly distributed across the population. We see that it varies depending on different factors. Varies based on age. Recognize once you're over 65, effectively, right, it drops down to zero, not quite. Children, we have additional plans. Medicaid picks up some things, Children's Health Insurance Plan. So kind of non-elderly adults running a little bit north of that. We see differences across race and ethnicity as we look at that. And certainly we, with more time, could unpack kind of why is that, what are the implications there. And then this is the Medicaid expansion point, right? Not surprisingly, in states that have expanded Medicaid, then a lot more people are able to get care than in states that have not, right? And so kind of these differences, they have to shape how do we want to think about it? What are you trying to accomplish as you look at your opportunities within healthcare? But the disparities are very real. Then the Affordable Care Act. So let me say a few words about this because it has been so fundamental over the last 20 years in more like 15, I guess, in the U.S. health care system and continues to be kind of an area of pointed debate. So when the Affordable Care Act came along, it had three objectives. And these three objectives are often what we talk about trying to accomplish in healthcare, right? We'd like to reduce cost, we'd like to improve quality, and we'd like to increase access, right? If we can do all three of those things, I would kind of refer to those as the iron triangle of healthcare, right? That we'd like to improve the system so we get all of those. The challenge, right, is often it's really hard unless we design entirely new ways of doing things to move them all at once, right? If I want to increase access, well, one way to do it is I just pour more money in, right? I'm going to invest more as the government. Okay, that works, but I've just increased some costs somewhere. I want to decrease cost. Well, maybe I cut access, or maybe I cut quality, right? These are things that we're constantly struggling with as we look at the design of the systems. Now, the goal was kind of across, and I'm not going to walk through every one of these factors, just because I don't think it's super valuable. In part because some of these were goals and that never got implemented. So IPAB is Individual Payment Advisory Board. It was meant to be a group. Turns out you can't change much of kind of health, Medicare, Medicaid, especially without acts of Congress. And so IPAB was going to come in and have independent authority to make changes that were better for everyone. it was part of the law, but never got enacted because all sorts of kind of politics then got in the way. It's like, no, we want to keep Congress in charge of this, was the decision that got made. Accountable care organizations as ACOs, we've seen different implementations there, trying to create more integrated care. Some successes, some question marks. On the whole, not tremendous movement on cost within the Affordable Care Act. Some successes, but small. On the quality side, directionally the same issue. They did things like, think about hospital readmission penalties. So set a baseline. This is kind of a percent of folks with a given condition that can come back in 30 days, and that's what we sort of define as good care. Right? Because sometimes people are going to have an issue. We did everything right, and something went wrong later. But what if you gave really bad care, and I'm just trying to maximize my profit as kind of an evil hospital that rarely exists, I didn't really cure them, but I took all their money, I sent them out, and then they come back with the same problem. And I take all their money and I send them out, and we keep doing that, right? And you can think about other contexts, right? The evil auto repair shop or something to take it out of healthcare. Now, what that did was say, hey, look, here's the percentage. If you're at this percentage, great. Maybe even if you're below it, we'll give you a little bit of extra reward. But if you come in above it, we're going to charge a penalty. And so you can think about the incentive there. Well, maybe that helps you make some better decisions. And so a little bit of movement there. Also, there's a whole lot of randomness that comes in there, right? And so that's the piece that's kind of tough for us to get our arms around. But we see some improvements, small things on that front. The big deal was access. We already talked about Medicaid. It put a whole lot of money in and said, hey, if you expand Medicaid, call it from 150% poverty level to 200%, then we'll pay as the federal government all of the money for the next X years. And then after those X years, you have to pick up your percentage. And so lots of states said, that's great. Like, we'll take the money and we'll worry about the budget implications later. Some didn't, right? As they said, well, we're worried about the budget implications. Or some didn't, maybe for other political reasons. But we saw Medicaid expand. The health insurance exchanges, most of us in this room will get our insurance from employers over the next 10 years or so. You'll go get a job, and odds are I shouldn't forecast. If you'd been here 10 years ago, this would have been a true statement. We'll see what the future looks like. Right, so University of North Carolina State Health Plan provides my health insurance. I put money in, right, and I get my care that way. Different big employers, right, have varying ways to fund it. If you're an individual, maybe you were unemployed for an extended period of time, maybe you're an entrepreneur, maybe you're an individual consultant, it was exceptionally hard to get health insurance because they were doing kind of the actuarial table and the struggle, right? When you look at different things, you're trying to forecast, well, how much are you going to spend? How do I set the price on it? And if I'm by myself, they're like, well, Brad's family had this instance of cancer a long time ago, and maybe he's going to get it too. And so you do out the math, and that's how much Brad costs. Issue is that was often way more than people could afford to pay, and so the individual market was fairly broken, frankly. It's all sorts of ways we can look at that. What this did was create kind of the benefits of pooling. Let's get a bunch of people into state-level markets and create rules about what sort of kind of services you have to provide and kind of how much profit you can make. On top of it, how much of the claims how much of the money that comes in do you have to pay out? Kind of that whole balance. And so they create effective individual market. And so the exchanges have been, in terms of access, a success as they've increased the ability to get care. There also were subsidies put in based on income. So, hey, and the federal government will pay for this much of your insurance as we look at it, right? So if we think about Affordable Care Act, you need to know what it is. Hey, ACA, hey, Obamacare, same thing, right? ACA, Obamacare, both capturing the same thing. Whole lot of moving pieces. Success in terms of access, right? Back to, this chart, we looked at here, right? A lot fewer people uninsured. However, questions around cost and quality is a fair description. Now, talked about kind of the uninsured. An important distinction is also around underinsured. And this is one that's a little bit challenging to get data on, that the Commonwealth Fund does kind of a every other year survey, I think it is, where they try to capture this and look at over time. And so think about this as, okay, hey, uninsured is I just don't have an insurance, right? So, how am I going to pay for that? I'm going to have to pay for it out of pocket if something goes wrong. Underinsured is sure I have a plan of some sort, but it doesn't really cover what I need, right? And so then the danger, if we think about this in an ideal world, my health insurance is covering the various things I need. I can pay my out-of-pocket components of it, and then I get sick, I go and get care. I need to get a drug to help me get better. I can pay for it, and my insurance covers the rest, whatever that looks like. But what happens if I'm underinsured, right? I have some, but not enough, and so maybe I can't afford my insulin, quite as regularly, so I skimp on it a little bit. Or maybe, I really should kind of go and get my shoulder set because I had an injury, but I can't do it, and it steadily gets worse, and now I can't work. And maybe I get fired, and then kind of worse things happen from there. But what we see, and kind of you can read the numbers, that of those who have insurance, a good chunk, they've got what they need, right? That 23% is saying, hey, almost a quarter of folks who have insurance kind of buy, and there's various definitions, but kind of aren't able to cover what's going on. 12% is during that last year, there was a time that they did not have insurance. And then in this sample, 9% are uninsured. And the reason I highlight this is to appreciate that recognize insurance is a complicated concept, right? In that it's not just do I have it or not. That matters. But it's also if I have it, do I have enough, right? What does it cover? How does it change my incentives? And so as you think about wherever you might sit around the healthcare space, right? Incentives are a big deal. How does it change behavior? How does it shape what we do? Okay, and here's kind of capturing this piece. Last comment I will make on insurance before we move to the next section. So we often talk about access as a story of insurance, right? Do you have it or not? And so in the US, right, we don't have universal access because not everybody has care. We can go to other countries around the world that have universal access and that everyone has kind of some sort of coverage, typically by the government. But access is not only do I have kind of that insurance, can I get the services that I need? And so one of the things that you see in the US compared to other parts of the world, not everybody's covered, but of those who are covered, they can get to services on average much quicker, right? How many months does it take you to get, that knee replacement, or to get in to see that specialist, or maybe even to get into primary care? And so this is part of the tensions that, okay, US, not everybody covered, right? We have that 10% group that's not. We have the number that are underinsured. But when people need care, they can tend to get to it, right? And this is kind of trade-offs that we have to think about when we look at design and the choices that we make. Okay, what are they buying? So told you 5 trillion, 4.9 trillion in this data. Where does the money go? And you can read, but what we see, right, is about half of it going to hospitals, physicians, and clinics, right? So kind of UNC Health Operations, big deal, doing amazing work, but those are the sorts of things that are soaking up the biggest chunk of our healthcare expenditure, right? So why do we kind of get in and wrestle with things like our payment models and what we're doing around kind of health insurance payers and such? Well, because that's where the money's going, right? We need to think about kind of what that's doing for us. We'll talk more in a second about prescription drugs. Super contentious, that's the word I'm looking for, area, as kind of we'll see in just a moment. But recognize it is worth highlighting. It is only kind of 9-10% of the expenditures. It's a little bit more because that's just the retail side of things, and there's some, in any sort of data, there's stuff buried all over the place. But it is worth kind of pondering, hey, we talk a lot in this country about kind of biopharma prices, and it's only 9%. How often are we talking about that hospital charge or that charge of the surgery or what that may look like? The answer is a lot less, right? And there's some good reasons for that. These are on average moving faster, so it's worth looking at. But also these are front and center, right? Most of us at some point have gone to a CVS or a Walgreens or wherever you go, needed to get your pharmaceutical at the counter, and then you're looking at that price and what versus certainly this is an age group that on average is not going to spend as much time in the hospital with suddenly a 5-figure or 6-figure bill that is driving some amount of what's going on there. Okay, so we see kind of expenditures varied, but half heading to the hospitals and then to the doctors. We can look at kind of growth by type over time, as we look at this, it's okay. Hospitals are the black, physicians and clinics the blue, retail pharma the green. And mostly I present this without comment. It's worth looking at and recognizing, on average those seem to be going up a healthy amount, right? That's pretty good growth for annual growth within a year. And often the green bar is the highest. If you stick around here, at some point you'll take a class from Marcus Saba. We'll talk about kind of biopharma pricing and this comment that in this phase it was kind of like do I take my pricing increase early, or do I just do it 10% halfway through the year, or do I push it a little bit longer? It was kind of constant turning. Here, recognize this number has a lot buried in it, right? So, if we look at generics, for example, not increasing in prices, right? Once drugs go off patent, then there's competition, price falls, and tends to, on average, be pretty flat. There are exceptions. On the other hand, we've got new treatments coming in, and also old treatments repackaged in ways that let one patent them again, and their kind of pricing skyrocketing up. So you'll get a chance to wrestle with that today, but we want to think about what this looks like, and then of course how this compares to other industries, right? It's still going up pretty dramatically. Then we can start to get into our cross-country comparisons. This is looking at a number of OECD countries and kind of what's happening year over year. So first comment that I want to make sure comes across is, if we look at just the absolute level in the U.S., what's happening there, and the U.S. spends more on healthcare per person than any other country in the world. Even if we just constrain ourselves to comparatively rich countries, we would expect, and you do see it, on average, rich countries spend more than poor countries, that the U.S. spends more, and this is kind of showing you your year-over-year growth. We want to think about, kind of over this next little bit, why is it we spend more, right? And what do we get for it? On that why component, recognize there's nothing inherently wrong with spending more, right? That, hey, guess what? There are treatments. We can now cure hereditary blindness. That's incredible. That's expensive. Not a lot of people have it. A bunch of money went in to discover it. And so the fact that we are a rich enough country to cover something like that, wow, that's amazing, right? I would individually put that kind of in the good category of possible spending. Then there are other places you might be like, but wait, isn't there a lot of waste? Are we doing things efficiently? Are we spending and getting on the other side? And that's where kind of there's healthy room for debate, that we can kind of think about prices and we can think about use, okay? So are we paying more per unit than the rest of the world? And are we buying more units? And to that, the answer is yes. We're doing both of those things in the US. Depending on what you look at, you can see which one is the dominating factor. One of the elements is biopharma. And so, I told you earlier, we shouldn't spend as much time, it's only 9%, and then I'm going back to it, because it is really important. And it's certainly front and center in the news. This chart is from 2017. I went and collected the data yesterday. This is actually one of the fun things of getting ready for today. So let me go back to all of these things and kind of refresh and be like, what's there, what's not? And basically what I found is the Directionally, it all looks the same, and this chart is just prettier than anything I could create, so I kept it. So now if we fast forward to 2025, the basic story is still there, which is in the US, we pay more for our prescription drugs than elsewhere. Now, there are a couple of things going on underneath that, okay? One is back to the access point. On average, in the US, we have access to more drugs than other countries do, right? How does this work in something like England? The National Health Service will then restrict. They have a certain pool of money. They're going to think about what goes in. How do we use that money as efficiently as possible? And they may say, yep, we're not approving this drug over here. In the US, it's much more individualized, and you may be able to get access to that drug that wouldn't happen elsewhere. Also, they may negotiate with a biopharma company and say, hey, we're only going to pay you X dollars. The company wants 1.5X, and eventually the company says, well, we're walking away. We're not going to sell our product here, right? Where the US has access to almost all treatments that are out there. There are exceptions, but as we look at it. So one of the elements is we have access to more things. The other element is on average we pay more, right? That the US, until the Inflation Reduction Act, the federal government, CMS, could not negotiate biopharma prices, okay? So there was a complicated way, it depended on program, how all these things got set, but it wasn't that someone was sitting down, hi, I'm here from the US government, it's time to negotiate the price for your drug. It was kind of out over here, and that meant prices tended to be much higher. There are now some mechanisms that are starting drug price negotiations, or have started, but it's still small, and the general gap sits there. Okay, so we pay more, we get more, we pay more. It's worth kind of digging into the data to understand it. There's also this use component. So what this chart tries to do, it's a messy chart, but the takeaway is exceptionally important. That this chart looks at our spending across kind of the population. Okay, so it's a really difficult one to calculate, so it's some old data, but it shows it better than anything else I've found. And so what does it say? It says, that 1%, the top 1% of the population that consumes spending, covers over 20% of the spending in this data. The top 5% are almost half of the spending, and over here, right, we're down at 3% for half of the country. Right? And as you look at this, in some ways, it's like, well, of course, right? We've got a bunch of healthy people that aren't consuming anything. Like, good, I'm glad they're healthy. They don't need to be spending. That works out well. A question that I want you to kind of be asked and then wrestle with, individually through life and later, and happy to have discussions around this, is, well, what services should be paid for, right? How far do you push this? So one of the examples, if your kidneys fail and you can't get a kidney replacement, you go on dialysis. And on dialysis, basically you have machines doing the work that your kidneys would have, and if that doesn't happen, unfortunately, then you're going to die. Just the reality of the situation, okay? In the US, we will let people be on dialysis and we'll pay for that for, many years, right, as we go along. In other countries, they will offer dialysis for a certain amount of time, right? It's a choice. It's extraordinarily expensive. It keeps people alive. Now, what is the quality of life at that stage? How does that look? All sorts of complicated factors there for, 9:15 on a Saturday morning. But the money is still being spent, right? And so, there are a number of things that go in here of what should be paid for. And then, of course, the other kind of giant piece is, and what might we spend earlier to avoid some of those expenditures, right? Not all of these are factors that are last-minute catastrophic urgent care situations. But the what do you spend on and for is a big part of healthcare, right? And we can't avoid it, right? It's not, hey, a luxury vacation, what kind of vacation do you take? We're like, yeah, great, that's an individual choice. Like, good luck with that. Have fun, go where you go, or don't go where you go and save it. Not a societal issue, I think. What any country, including the US, pays for, well, that's negotiated, right? That's politics, that's working through the different pieces and trying to understand it. So spending higher, big takeaway, spending's higher because our prices are higher, often. Spending higher because we use more. And so if you want to reduce spending, you got to think about both of those factors and how do you tackle them. All right, so then kind of how's it going? Let's start with the good. At its best, the US healthcare system is truly exceptional. What this chart, why do I like this chart? Well, I mean, this is lung cancer, but we can look at lots of things. You can get treatment here some treatments maybe only here. Some treatments, a small selection of countries, right? That if you think about folks traveling from all over the world to some of the greatest academic medical centers, right here, right? Because of what we've been able to do and what we continue to do. And so that kind of high end is amazing. The discoveries that keep coming out as we think about kind of the new, whether it is a biopharma, whether it's looking at medical devices, I mean, all sorts of incredible innovation. And so we absolutely should celebrate that. We also, though, kind of need to recognize the variation in outcomes that we get. So what this is looking at is life expectancy and expenditures. And as you get deeper into healthcare, you'll appreciate that life expectancy is an interesting I'm going to say it's an interesting but flawed measure. As a human, it's an extraordinarily important measure to me. But if we look at it on averages across populations, it's challenging to understand just by itself. But it's still worth considering. The size of the circles are how big the countries are. Y-axis is how long on average people are living. X-axis is kind of a normalized health expenditures. And so what do you see? Well, I told you the US spends a lot more money. We don't seem to be buying a lot more life in return for it. Now, this is an average across the population. As you start to break it down into different demographics and gender and things like that, the story gets more complicated. As we see, some groups are winning more than others. But I think what this highlights is, certainly begs a question. Why is it that Switzerland's spending 2/3 of what we're spending, and at least on this measure seems to be doing better, right? And a number of things go into that, but at least part of it is some health system related factors. There are other elements of societally how are folks approaching things. How do we think about, and this becomes in what do you include in the group? How do you think about vehicular deaths? People driving on roads shows up in this. How do you think about gun deaths is going to show up in this? How do you think about alcohol and drug death in this? In addition to what's the healthcare system doing?
Do data like this ever account for how homogenous other countries are, maybe geographically, culturally, compared to the US?
Yes. So it's a great question. And this is the fun part. I hope as we're talking at various times, you're like, oh, that's cool. And to the extent it is, what I'd say is depending on where your interests are, great, hey, you can go work in that space. That question, hey, you can go get PhDs, certainly Gillings and other places, and unpack that in immense detail because we need to understand it, right? I mean, I'm getting to paint in that broad brush. And yes, part of the reason is, we're going to shrink down. If we take that and we blow that up across states in the US, because in some ways states are more comparable to some of those countries we're looking at, you're going to see it get a lot more complicated too. It's not that every state is sitting right there. You're going to see kind of some states doing much worse, some states doing better for some of the homogeneity reasons. So big variation in outcomes. Variation in outcomes across states as well. So it's just highlighting that kind of big picture. This is looking across the state of North Carolina, and this is heart attack mortality at the county level. And why do I highlight this? For really this chart makes 2 points that I really like. One is in a state like North Carolina, you see, right, kind of big differences. We're 100 counties. We see kind of counties doing really well. We see counties doing poorly, and we can think about what's driving that. Some mix of, do they have the care? How far do you have to go to get it? What about just the underlying state of the population? How well are they taking care of themselves? Can they pay for things? Do they have insurance? All those are going to be factors. You also see those gray counties. And with those gray counties, some of what you're capturing is a lack of data, or you are capturing a lack of data. And some of that is a story of just small numbers, they're small counties, but some of that is incompleteness in data. And this is a constant challenge in any industry, but it's certainly true in healthcare. Data continues to get better, but we don't, as much as we're like, oh wait, I want to pull this data. Sometimes we can, sometimes we can't. But the highlight here, dramatic variation at the country level, at the state level, as we think about it. And this is my last slide, just to offer kind of a few concluding remarks, and then if we have time for questions, great. So kind of 6 things to consider that I'll highlight for you just throughout the day and for your exploration in healthcare. Okay? We've talked about the costs, right? That at least on average, they're high. We want to think about what we're getting. Is it kind of worth that expenditure? How can we do better, right? Wherever the baseline is, we want to constantly be looking to improve it. Workforce challenges, this has been kind of a key point, and it's just which workforce challenges we want to talk about, right? We can think about them from the provider side in any part of the space, right? Nursing is a great example to look at. Kind of nurse attrition continues to be a significant challenge, absolutely critical to our success in delivering care. And, COVID certainly spiked the issues there, but they continue. And so trying to think about whatever kind of, whether it's the care side of things, whether moving into biopharma, payers, et cetera, what does this look like kind of strategically? How do we do more with workforce? How do we think about things like, and this will be related here too, with artificial intelligence, where does that create opportunities for us? Where does it create real issues? What are the ethics of it? All goes in there. I've highlighted the outcome cost challenge, at least in some places, poor outcomes compared to the cost. Something you always want to be thinking about in healthcare are incentives. You want to think about it in any organization, right? I'd encourage you, right? Incentives front and center. What are the incentives? We haven't gotten into it, but one of the challenges traditionally in healthcare, it's been what we call the fee-for-service space. This is back to kind of the managed care story, right? I produce something, I offer a service, I run a test, whatever it looks like, I get money for it. And so just every time I do something, I get paid. And the challenge is, well, what if that's not well coordinated, right? Instead of paying for the outcome, I'm paying you for the action that you take. And so often it might be something like, hey, I got an MRI, and spent whatever it was, and then I moved across the country, and now we're better on some of our digital sharing, but we're not perfect. And hey, we're going to do the MRI again, or maybe it's a smaller test, but we repeat things. And so how do we try to drive that improvement in outcomes? We've talked about kind of really I should just call this disparities, right? Differences in populations. And kind of the health implications of that. Often it's economic, but it's not only economic. There are a bunch of factors that go into that. And so how do we engage with that in a really honest and thoughtful manner, right? Appreciating that, if I would say our goal is, hey, we want to get everyone, right, kind of in a healthier spot, then we need to deeply understand what are those bottlenecks that get in the way for whatever the reason might be, given our differences. AI is a piece here, but one of the challenges as we look at healthcare is also the exciting pieces. We can do things we never could do before, right? Then we have decisions to make of, well, what are we going to pay for? How does this work, right? We can look at things like drugs. The whole GLP-1 class of drugs are able to do amazing things in terms of weight loss. Different clinical data coming back in suggesting they can maybe apply a number of other places too. But then a question becomes, well, who's going to pay for that, right? How do we fit that into a system that's already creaking a little bit? And again, maybe it actually solves a bunch of problems because 30 years from now, we don't have people that are dealing with chronic obesity, leading to diabetes, leading to other comorbidities that are making them sicker, and the system's having to pay more money, maybe. But often, with our technological advancement, we can just simply do new, better things for people, right? And we have to be able to pay for that. So that's why costs going up could be a good thing, right? If we could extend everybody's life by 20 years equally good, with more money, I think you'd look at that and, I mean, sure, any question, some people will say it's a bad idea. But many people are like, that's amazing, we should do that. But then you got to figure out how to pay for it, right? What does that look like? This last piece is one that kind of ebbs and flows, but for many years, what we've seen in healthcare and a desire to get more coordination is that, you know, we've seen kind of purchases, right? So United Health Group is kind of the classic example of this right now, exceptionally large, as they have gradually moved across more and more aspects of healthcare. And there's some really good reasons for that. As you put your arms around multiple pieces, you can coordinate them, you can get them to work together, and hopefully deliver some better outcomes. There's also just some classic kind of go to your econ, you know, if you haven't taken econ, that's okay too. Think about, you know, what happens with monopolies or duopolies, right? That, you get pricing power. And are they going to use that power for the patient and the customer? Or are they going to use that for their shareholders? And how do we kind of fight it, you know, wrestle with that question, right? And so I think across all of this, I guess I'll end with sort of where I started. You know, thanks for being here. I personally view there's no more important topic than health. Our ability to do truly amazing things right now is we're in a place that we've never been. And tomorrow will be even better than today. I am absolutely an optimist with all of this. At the same time, you know, there are a lot of challenges here. There are a lot of things that need attention. And eventually, change is driven by those who show up. So thanks for showing up and being a part of what's going on here and what's going on across this entire campus. If I can be helpful, I'm easy to track down. Please reach out to me. I'd love to chat more. And I think, given timing, I'll hand it off to Suzanne and let her jump into CBOH stuff. So thanks, y'all. Appreciate it. I'm happy to. People have questions. I'm happy to take them. Yeah.
Hi, my name is Emmanuel. I'm one of the graduate students at Gillen's. So regarding like the uninsured population, like do you know what specific metrics a lot of healthcare systems use to determine if insurance is enough? And in your opinion, what are like better ways to kind of like improve on that?
Yes.
Because I feel like enough could be also very subjective as well, making it very complex.
It is, right? So, you know, this particular one, right, they're judging the underinsured as a result of, right, premiums are 10% more of household income. You know, that out-of-pocket was 5% of household income. If, you know, kind of, and then it kind of has different categories. So, you know, what I'd say is, right, there's how the researcher approaches it, and we have to kind of create some definitions of it. I think one of the things as we look at incentives is appreciating who's thinking about what problem, right? So if you're the hospital, if you're the health system, I mean, you were conceptually thinking about it, and there are always individuals doing things, but your incentive is to deliver care. You're trying to do that as optimally as possible, so you're not thinking as much about the underinsurance problem. If you're the payer, then maybe you're thinking about underinsurance, but you're also thinking about market, about design of benefits, about the competitors you have. You know, some amount of the underinsurance happens because sometimes people truly can't afford things. Sometimes people make different choices. And they buy a plan that's not a good fit for them. Now, why do they do that? Maybe it's they don't have the health literacy to do it well. Maybe they just choose, I would rather X than Y, right? That's an option too. And so the complexity is kind of who's in charge of that decision, and that's actually a really important point about healthcare and why this understanding the system is so valuable, of who's tackling it, right? And the policymaker cares greatly about this if they choose to. Some policymakers not so much, depending on what they want to prioritize. So is that I mean, the fundamental answer is yes, you have to categorize, and they are somewhat arbitrary. You know, those standards, they've just set a standard. Yeah.
I'm curious, looking at like the IRA and that 10% figure.
Yep.
How much is that projected to decrease prescription drug, like the percentage?
Yes. So, important lesson when you work in healthcare is you need to lean into I don't know. that inevitably you're going to get questions that you don't. So I don't know is the answer. Now, recognize, depending on where you sit, I don't know, but I'll find out, is how to encourage you to approach it. I think part of the question with the IRA kind of negotiation, so the Congressional Budget Office has estimates. I just don't remember them off the top of my head. But one of the struggles here is, how is that change going to affect subsequent innovations of what comes into the market? And also, one of the issues, right? So if you go back, for most people 5 years ago, weren't thinking about GLP-1s in the expenditure category, right? There's lots of innovation. They existed. People were thinking about them. But that one of our struggles in forecasting this is, well, what new treatments are coming online that suddenly we're going to say, well, absolutely, we should spend money there, and it's going to keep it growing.
Yeah.
And then back to who makes that decision, right? Is it the individual? In other countries, there's kind of a central bureaucracy in charge of that. It's much more diffuse here.
Okay, thank you.
Yeah, of course. Yeah,
So
Bradley.
you referenced that Medicare and Medicaid makes up the majority of healthcare expenditure from the government.
Yep.
We're also seeing major cuts as well with Medicare and Medicaid.
Yep.
So where do you think those patients will go? Will that increase uninsured rates?
Yeah, right. So in the Big Beautiful Bill, part of that was kind of reducing expenditures around there, in particular on the Medicaid side, kind of for doing a handful of different things. I don't know. I think the forecasts are that there will be fewer people covered, and then, kind of, if we look at, there are different ways that folks get coverage when they're in that uninsured category, right? It tends to be then the preventative stuff goes away, the emergent care gets picked up because it has to be. This is part of why kind of hospitals were so kind of in favor of ACA and expanding access that way, because it was getting them payments for things that in some cases they were having to do. Ditto some amount of the pushback around that. Many of the cuts, as I believe I understand it, are delayed in terms of when they're going to get implemented. And so I think in a political system, it's always fair to ask, well, will we actually implement those, or will Congress implement those? But fundamentally, take something away, the money's not there, somebody's not going to get things anymore.
Hi. So you said that 30% of the healthcare spending goes to the hospitals. There's also a surge in PE-backed hospitals and increasing privatization. Would love to know your the proportions right now of public versus privately owned hospitals and how they're changing.
Yes. So that is a great question, and one that gets really complicated really quickly, right? So we can think about, and we can use hospitals, but different care delivery mechanisms. Hospitals can be owned by the state, like UNC hospitals. They can be kind of in the not-for-profit space, but recognize that means they're under a certain set of guidelines that many not-for-profit hospitals are still actually doing a fair bit of maximizing of profits. So we have to kind of be careful as we understand it. We've got for-profit hospitals in the traditional sense, HCAs that are public companies, and then we also have private equity coming into a number of these places, looking to generate returns consistent with what their investors expect in that private equity area. I think the easiest answer given our time, I'll go with this story. A few years ago, the center each year we do kind of a big research symposium. We're trying to take a meaty question. This year's was strategic workforce. 3 years ago is private equity good or bad for healthcare? And the answer is yes. It is. Because again, you can think about this. Where are the incentives, right? Go back to incentives. Where are the incentives in private equity going to align with they allow us to improve care, they improve efficiency, and overall kind of good things can happen around that. And there are a number of spaces that innovation has come in that we need that coordination. We roll up an area and kind of the incentives are aligned so nobody's taking advantage of anything, and we see success. There are also a number of places, nursing homes are an example where there's been some good research that people come in, they basically squeeze expenses, they cut staffing, quality goes down, but they're able to get a return that way. So they're, I won't even say inherently it's good and bad actors, although occasionally there are bad actors. It's more, sometimes the incentives encourage people to do good things, and when the incentives encourage them to do poor ones, we shouldn't be surprised that unfortunately people step in. And that's why we're back to, you can't avoid government and private industry having to work together as we think about health, because at the end of the day, it's about our lives. And you're never going to get things written so beautifully that, oh, nobody needs to oversee this. We need regulators. We also need kind of industry and innovation that comes with that. And so how do you bring them together to get as good outcomes as possible? Yeah.
So for the figures of per capita healthcare spending,
yep.
I had a question on that, kind of related to, I'm going to use two examples for it. So say for the U.S., is that saying I myself out of pocket am paying $12,000, or is that a mix of myself, insurance, and then so I'm going to use Germany for an example, where they have a nationalized healthcare. Is that how much is coming straight out of their taxes, or is that also a blend of their taxes mixed with federal subsidy?
Exactly. So that's trying to capture the total expenditure around you that's going to go around the average person. Inevitably, none of us in this room are the exact average person as we think about it. An additional extension, so where it comes from looks different. I'd encourage you, if you're interested in healthcare, go spend time on Commonwealth site, go spend time. Kaiser Family Foundation has phenomenal data to look at. The Kaiser Family Foundation has some great charts looking at, for that average expenditure, how much is paid by the individual, how much is paid by companies, for example. And what you see is over time, individually, we are paying for more and more in our premiums, in our out-of-pockets in the U.S. The other piece that this doesn't capture, a critique of this, would be there are other, you try to pull it apart as cleanly as you can, but thinking about social services and what other things are being provided that might fall into a different category, but might actually kind of affect health. And in a number of these countries, there are going to be some things there that certainly affect this as we look at it. So,
let's do one more big, beautiful question here, and then we'll get on.
Talking about beautiful questions, I was thinking about the bill and how the public health, preventative services are due to be cut to, and how a lot of the hospital systems are going to have to cushion that. What does that look like? Who takes the impact of that? Who's going to pay for it?
So this is kind of the classic, a number of things, won't happen anymore. One of the pieces to recognize, and it's worth kind of stepping back, federal priorities drive federal spending, state priorities drive state spending, and in the simplest form, turn off any of those, then the question is, does somebody else rush in, and provide it? I think we'll see. This isn't a very difficult prediction. As this comes down, it won't all get filled, right? Some states will have the resources and choose to deploy them. Plenty of foundations will step in. Some individuals will, and then some things won't happen anymore. And kind of the argument, and you'd have to get into individual choices. Some of those things, people would say, well, that's good we're not doing that anymore because that wasn't actually providing value, so it's saving money by not doing it. Some of those things, we could have debates on and be like, oh, I think that's actually really bad that we're not, because we're not preparing ourselves for what may come later. And that's why, whether you go into healthcare or not, and whatever country you end up kind of in to spend the next chunk, I would encourage you really strongly to be a part of these debates. Right? Pick anything we wanted to, and across this room, we could have really healthy discussion about should we do X or Y. But have that discussion, right? Your voice really matters because there's meaty stuff here. And occasionally there's an obvious right or wrong answer. And that's great if we get to that. Far more often we got to struggle with, because often it's, do you put the money in this or do you put the money in that? And so kind of informed citizenry, wherever you may be, are exceptionally important. And that's kind of a great way to end it and hand it off to Suzanne. So thanks, y'all. I appreciate it.